It's an honor to be here. We're going to talk about some simple primary cartilage defects, then we're going to move on to more complex revision settings, then issues with concomitant pathology. You're going to see that I have an updated transition here to my slide. That's not what it is originally. You're going to see really cool 80s pixelated transitions because unfortunately the original way it was set up is not presenting, so I apologize for that. So we're going to start out by talking about how to treat defects that are incidental. Should you treat them or not? If they're not incidental, what's some good first-line treatments as far as debridement, microfracture, or an OATS, or osteochondral autograft transplant? There's also some other treatments out there as well, which we'll touch on, but there's a little bit less evidence there, so I don't want to spend too much time on it. When we look at these, first of all, the overall rate of incidental cartilage defects is very high in standard knee arthroscopy. And you want to make sure that you're really clinically indicating these appropriately because there are side effects to these. You can have complications, you can have worsening of pain, and there's also usually, if you're following the protocol, a significant impact on the patient's life as far as weight-bearing status, CPM usage, and there's also a lot of variability in that as well, so we'll cover that moving forward. This is just an example of a medial femoral condyle cartilage defect, and so you can see here that this patient has a grade 4 lesion. There's relatively well-defined walls. On the posterior aspect, though, there is a flap of tissue here. And so these happen to be the patients that I think that might benefit from a debridement, for instance, because this really can be a hangnail that does impact the bone deep to it, almost like an exposed nerve root. Similar here, this is a lady with a patellar cartilage defect. She had significant mechanical symptoms with going from flexion to extension and her patella transitioning over the proximal aspect of the trochlea. This is an examination under anesthesia where we're pushing the patella down and moving it proximal to distal to show how that really grinds over. And it's so significant for her that she really can't move her leg from flexion to extension actively because it's so uncomfortable for her. It also goes over the medial trochlear ridge there, and you can see it engage as well. This is one final example of a patient that has loose cartilage flaps. This is a relatively significant version of it. This is probably on the spectrum towards osteoarthritis. You can see that's a grade 4 defect there. And then over medially, you can see there's a large sheath of cartilage that is completely delaminated here. So this is not a cartilage transplant patient, but certainly this patient could have symptoms related to this, even if it's not pure mechanical symptoms. And so what we're getting at here is that debridement still can be pretty powerful. And we looked at patients that had 2-stage cartilage procedures at our institution. We started with almost 260 patients. We narrowed those down to 90 that had outcomes that were available for patient-reported outcomes. And we saw that half of the patients that had an initial staging arthroscopy did not move forward with a cartilage implant procedure. And so the question is, why aren't they doing this? Why aren't they moving forward? And we looked at where these were located. So our practice is a little bit biased towards doing more biopsies to the patella. So there's certainly, that was most of our group, but there were some that were on the femoral condyle as well. When we separate out who was getting implanted and of the people that weren't, why they weren't, most of them had symptomatic improvements. So they just felt better and they didn't feel like they needed to move forward with any further treatment. So again, I think that's a really important take-home, is that you really should not be treating incidental lesions. So if they have no pain, very hard to justify any treatment. And even if they have pain, if you think you have a good reason to have other sources of symptoms, whether it's a small meniscus tear or a flap type tear, just do a debridement alone, and sometimes they'll get better. And certainly you've only put them through one small procedure that doesn't have significant risks to it other than anesthesia. So we need more detailed information for the femoral condyle. This data is biased towards patellar cartilage defects, but it's possible that we're going to see something similar in the femur, and we're looking at that now. Moving on to microfracture, which has been the workhorse of cartilage restoration over the last 20 to 30 years. This is a marrow stimulation technique where you're trying to get the mesenchymal stem cells to come out and try to produce cartilage. It produces a good scar that is a fibrocartilage. It's certainly not normal cartilage. And there's a lot of variability in the way that this is performed and the way that it's handled after surgery. And so this was a nice Canadian study that just was a survey study looking at whether or not surgeons are removing the calcified cartilage layer. We're going to have a separate microfracture techniques talk as well, so I'm not going to get into too much technique detail. But the calcified cartilage layer is important to be removed so that you get good integration of the cartilage with the subchondral bone. And a lot of surgeons will perform microfracture because it's available and it's cheap and it's relatively easy. But 27% of non-sports surgeons don't remove the calcified cartilage layer, at least in this study, and still only 65% attempt to do that, even if you're sports medicine trained. And that really should be hopefully 100% at one point. The use of CPM and restricted weight bearing was extremely different too, so you can just see that this will get kind of thrown in situations where it's not really given a fair advantage, whereas if you put in an osteochondral allograft, meniscus transplant, HTO, you're not going to say, well, don't worry about range of motion, and you can just walk on it right away. So they're just not treated quite the same. This is another example from that same study of the age that it can be applied to. So certainly this is a broad spectrum, and there's other studies that look at much better indicated age groups. But there's still a lot of this that's being performed in patients that are really over the cutoff of what really should be clinically indicated. And over 40 years old, I think you should have a really good reason to be doing this. Same thing with the weight-bearing restrictions. So about half of people are making patients non-weight-bearing, which really seems to be crucial. There actually is not a lot of good basic science data behind it, but it certainly has been dogma in the cartilage world, and it's still the conservative treatment of choice for postoperative care. How you perform microfracture probably affects its outcome as well. And again, I'm not going to get into too much of the technique, but basically you do not want to impact too much bone. So you can see on the bottom right, that's an awl that would impact bone more, whereas the one above it kind of splits the bone so that you don't create, you want to maintain access to those marrow channels. And so things like a K-wire or a fluted drill are probably a little bit better so that you actually maintain that and you don't impact the bone, around that area. When we're looking at outcomes, Kreutz had a study showing that outcomes over 40 certainly go down. The success in the patellofemoral joint is lower, and when defects are getting larger than 2 centimeters squared, that's also less beneficial for those patients. They also seem to deteriorate over 18 months. Some other studies have shown that it's 2 to 5 years, but certainly the microfracture outcomes don't seem to be durable, and that's probably the main complaint with them. This is a nice study by Saltzman looking at the preoperative duration of symptoms. This almost always comes up as a correlative factor for cartilage defects and their outcome. The longer patients are having symptoms, the less likely they are to improve as significantly as patients that are having shorter symptom duration. That doesn't mean we should be more aggressive. It just means that their disease process may be changing, and it's an important part for consultations. I still do a lot of injections and non-operative management of these patients as first-line treatment before we get to the stage of doing surgery. This is just reinforcing the fact that the patella is the worst outcomes of all the locations for microfracture. Also keep in mind that's a sesamoid bone. There's no significant marrow cavity. Nobody would ever ask for a stem cell transplant for lymphoma or something from somebody's patella. So there's just not a lot of good stuff in there compared to the femur or the tibia. This is a little bit of a different study out of Asia, but they did microfracture in patients where they're basically pushing the limits. And so these are borderline arthritic patients, but they even still found that there was a significant difference based on the size of the defect that was being treated. So 2 centimeters squared was what they looked at as a cutoff, and they found difference in overall survival. You can see that they still had 80% survival at 6 years for the greater than 2 centimeter defects, which is a little bit rare, but still a difference between the two. This is what I think is more interesting. So they also looked at overall alignment. So if patients had varus malalignment, they had a microfracture of the medial femoral condyle, this significantly worsened their overall survival. Again, this is over a long period of time. But again, I think a lot of surgeons would probably not do a high tibial osteotomy in association with a microfracture, so we probably don't give it really the advantage that it should have compared to other cartilage procedures. Also, this is Petska's work, but there's multiple groups that have looked at this, including Minus and Gamal, ACI following microfracture, and there also seems to be decreased survival rates after a prior microfracture when you perform ACI or now MACI. And this is really reoperation rate. The PRO difference is not as significant, but certainly the reoperation rate does seem to be different. So these are the first papers to really start saying that maybe this could burn a bridge, maybe this is an issue. Now, they'll talk more about it, but it doesn't seem to hold up when you do an osteochondral allograft because you're just replacing the whole osteochondral unit, and so you really bypass that. We'll move on to talk about OATS. Just make sure that you use the terminology appropriately. So OATS is an osteochondral autograft transfer system. It's like saying Kleenex as opposed to tissue paper. It is a branded term, but also it does not apply to osteochondral allografts. So if you say OATS, that should not be referring to an osteochondral allograft. An OATS is a transplant of osteochondral plug from a non-weight-bearing portion of the condyle, either superior medial or superior lateral ridge or the notch, which we'll do a technique video on later today. And then that could be a single plug or multiple plugs, but usually the maximum plug size is 10 millimeters, so the size defect that you can treat is limited, and the chance of you going up to multiple plugs is relatively high. This is a single-stage procedure, which does make it attractive. It does transplant articular hyaline cartilage that's already formed. You only need bony integration and edge-to-edge integration, just like an osteochondral allograft. However, you are bypassing that debridement step that we talked about. So I think that's one of the questions here is it really worth going straight to this and possibly having donor site morbidity versus giving them an attempt at debridement and coming back with something that doesn't require a donor. There are limitations in defect size, as I was talking about, as well as the surface congruity and continuity. So the more of these holes you put in, the more relative surface area there is on the periphery for these to integrate, and really the higher the likelihood there is of you having issues like subchondral cyst formation. The indications vary for this, but certainly they're talked about between 2 and 4 centimeters squared. 4 centimeters squared is getting relatively large. That's a fair number of plugs. There may be better outcomes in athletes or high impact or high demand patients. And again, in a small failed microfracture defect, it's a consideration. Hangoody had a good study looking at over 1,000 patients, and they showed good to excellent results, 92% at 14 years for femoral condyle lesions. This is really great outcomes. You can see that it does decrease when you get to the patella. And the donor site morbidity overall complaints was about 3%. So it's relatively low, but it's still hard to know if you should really be able to tolerate that, especially with some other things that have come to market now, like fresh osteochondral allografts that are available off the shelf that are the same size as these plugs. And so there's a question as to whether or not that's going to avoid some of these issues. This was a systematic review by Critch looking at 10 different studies, and they saw good outcomes overall, 72% with long-term. Mainly, again, the outcomes changed with age as well as the size of the defect, and previous surgery was also a significant negative prognostic factor, which is usually the case for most cartilage transplant surgeries. So we're getting closer and closer to saying that you should just do one main thing hopefully first, and then that's all is your definitive treatment. Gudis has probably the most popular study, which is an RCT looking at Oates versus microfracture. This was in athletes and lesions 1 to 4 centimeters squared. Oates had the best outcomes as far as the amount of good to excellent results. It was almost twice as much as the microfracture group, and the return to sport rate was almost double as well. And so that's why we think that patients that are really more active may be benefited by putting in that structure initially so that they don't have to grow the cartilage essentially. This was the follow-up of his same study at 10 years, and it showed that there was still better resilience and durability for the Oates group than the microfracture. They both still had significant improvement by 10 years, but the overall failure rate was significantly higher for microfracture as well as the return to sport difference. So there's been other systematic reviews looking at all the RCTs of Oates versus microfracture, and really the clinical outcomes are very similar, but you really have to start looking at more specifics than that. And so the size of the defect, the location, the activity demand of the patient, the prior surgeries, the length of symptoms leading up to surgery, all that stuff really plays a role, and certainly this type of study doesn't separate all that out. I'm just going to mention that there certainly are other single-stage treatments that exist, and so these can either be a cartilage sheet that does not include any significant amount of subchondral bone to it, so much so that you don't have to do any excessive preparation of the bed of the defect. There's also microfracture plus type procedures, which is an augmented version of microfracture, which is below the FDA bars, so more and more of those are coming out. And that again gets to the question of how much should we do primarily versus doing stage procedures to allow debridement to be successful. And then there's been other synthetic plugs that have come to market. A lot of those have come and gone, and so I think most of the ones that tend to stay are the ones that really use living cells and that have good viability. Thank you very much.